Sure. I was a full scope OB-GYN practicing in Iowa in an underserved community. And I really just considered myself an absolutely normal OB-GYN. I did not have a remarkable practice. I practiced according to ACOG guidelines. And I just tried to do a good job taking care of my patients in a very normal and standard way. What I believed is that these patients with gender dysphoria had such profound psychologic and mental pain because of their gender dysphoria that the only way to alleviate that pain was to pursue these medical interventions, such as hysterectomy. ACOG issued guidelines saying that hysterectomy for the purposes of gender confirmation is medically necessary. So I assumed that indeed it was medically necessary. It was really just like a clinical dilemma to me. What should I do with a non-binary patient who wants a hysterectomy for gender affirmation? So I reached out to a group of OB-GYNs who talks about clinical issues and asked the question. And I was very surprised to get back a number of responses. First of all, sort of accusing me of being transphobic for having this question or being bigoted, which I certainly knew I was not. And I was also surprised that all the leading experts in the topic at all the best academic institutions said if a patient endorses a non-binary gender identity and desires a hysterectomy, then hysterectomy is medically necessary. The general medical community. It was just well known and accepted that WPATH were the experts on the care of transgender patients, and everybody pointed you towards the WPATH guideline. The Center of Excellence at UCSF, if you had any questions about how to take care of your transgender patients. I looked at the WPATH Standards of Care 8 guidelines in an effort to find out more information about how I should proceed with a patient with a non-binary gender identity, because this situation seemed less straightforward to me. So I thought if I looked at the chapter on non-binary gender identities in the Standards of Care 8, I expected that I would find some kind of checklist or criteria for when a patient with a non-binary gender identity needs a hysterectomy or when a hysterectomy would be medically necessary for that patient. And I didn't find that. Essentially, it just said, well, a patient with a non-binary gender identity needs a hysterectomy if they desire a hysterectomy. And to me, that just seemed very implausible. I learned that the WPATH had intentionally suppressed the research that it had commissioned about the science behind gender-affirming care, particularly for young people. So I just thought that it was good information for leaders in my professional organization to have. Because I think a lot of the people who are taking care of these patients legitimately believe that they are practicing according to a good evidence-based and best practices that are grounded in good science. And I really wanted to make people aware at my organization that they were not. That WPATH had not accurately represented the research that went into its guidelines. First of all, I started writing an article that really laid out what I had found, and I was trying to make it really easy for people to understand, even though this is a long and convoluted topic. And I was really writing it for physicians. And so I started emailing people, leaders in my organization, saying, this is an article that I'm working on. Please take a look. I think that the WPATH guidelines are based on misrepresentation, and we should really revise any recommendations that we are giving our members that are based on this document that was not ethically composed. The response I got from the institution, though, was not, oh, wow, there's a problem with this evidence. It was, oh, wow, you can't publish an article that goes against our official guidance. Okay, well, I don't have to publish it then. Fine, I won't publish it. We won't, I don't want to cause a problem. Can you please just look at this information that I'm giving you, because I think it has really significant implications for how we're taking care of our patients and what's best practices and what's best for our patients. It really just did not seem like anybody in this organization had the will to consider that we might be wrong about this topic. And it was a topic that I cared about. So I did go ahead and I published the article. And after that article was published, I was summoned for a meeting with my supervisors. And they said that I either had to stop talking about this publicly or resign as the chair of Iowa ACOG. So I chose to resign. First of all, we need to have credibility as a field so that we can take care of our patients. We cannot build trust with our patients and take care of them well if they cannot trust us. And if we, as a profession, are saying things that are easily seen to not be correct, then I don't see how we can expect people to trust us on other things. And the other reason that I care is that most of these young people, if we left them alone, would simply grow up to be perfectly happy and healthy gay and lesbian adults like us.